Tonight, as we mentioned, we're going to be discussing latent autoimmune diabetes in adults, LADA, also known as type 1.5 diabetes, a form of type 1 diabetes that has features of both T1D and type 2. LADA is estimated to account for approximately 10% of adult diagnoses of all diabetes. LADA has been the subject of debate in the field. Some consider that this is a distinct subtype of diabetes. Others consider that it is simply a slower progressing form of T1D. Regardless, developing a personalized care plan with your healthcare team is important to live well with LADA. We'll be learning more tonight about the latest treatment options and how to best manage the condition. Here at Breakthrough T1D, we consider people with LADA as part of our overall Canadian type 1 diabetes community, and we hope that this webinar will encourage more participation in our programs and services, and also that some of the research we help to fund may have a benefit for people with LADA as well. And it's now my pleasure to introduce our speaker tonight, Dr. Kathy Sun. Dr. Kathy J. Sun is an endocrinologist at the Ottawa Hospital, associate scientist at the Ottawa Hospital Research Institute, an assistant professor at the University of Ottawa. She graduated from medical school, endocrinology residency, and Masters of Science at the University of Ottawa. Dr. Sun then completed 2 clinical research fellowships in lipidology at the Ottawa Hospital and in diabetes mellitus at the Montreal Clinical Research Institute. Dr. Sun's clinical expertise and research integrate pathophysiology into advancing the understanding of diabetes heterogeneity to personalized treatment for people living with diabetes. Furthermore, she is committed to improving the quality of care for people living with diabetes when they are admitted to the hospital. And Dr. Sun is also passionate about knowledge mobilization and developing innovative methods to increase access to comprehensive diabetes care. We're so grateful to have you here tonight, Kathy, and I would like to turn it over to you now. And you are muted. Are you able to unmute yourself? There you go.
Yes, and then I think I have to share my slides again. 1 second.
Okay.
No worry, just take a sec. Okay, good. So you can hear me now?
We can hear you, we can see you, and we can see your slides.
Perfect, thank you. So thank you very much to the team at Breakthrough T1D for the invitation to present today. So I'm Dr. Kathy Sun. Thank you all for coming. So our topic is latent autoimmune diabetes in adults, and as was very well done in the introduction, it's also called LADA, L-A-D-A. And so here starts our voyage with LADA tonight. So just a few disclaimers. So please note, I do not have any relationships with commercial interests, and there's no potential for conflict of interest. Everything in this presentation are based on my clinical experience and interpretations of the literature. I've also discussed some of the content with my colleagues as well, and also had their input. This presentation is not medical advice. So for medical advice, please consult a healthcare provider for yourself. Okay, so these are the objectives of this presentation. We'll start with how did LADA become a type of diabetes? We're going to discuss the features of LADA, and then what are the treatment options for LADA? And finally, after we've discussed all that, we kind of use it all together or show you how it's all incorporated together in some examples of common real-world clinical cases where LADA becomes the diagnosis. So the history of LADA, latent autoimmune diabetes in adults, the term was first used back in 1993, and it was actually a group of clinician scientists who saw an observation. They were observing in the people that they were treating that there was a rather unique form of type 1 diabetes that progresses slowly. And this slow progression is in comparison to the so-called classic type 1 diabetes that takes a certain trajectory or a certain route. But they're like, but then there's this group of people also that they were saying as type 1 diabetes, but they're like, how come the progression is much slower in this group? And then they also observe that, hey, this is also a group of people that can be treated for a while without insulin after their diagnosis. So it initially came as an observation. And then from 1993 until today, basically, there's various definitions and diagnostic criteria, but it's still a very complicated field for many reasons that we're going to explore. So here I just want to bring the idea of the spectrum first, just to kind of keep that in mind for all of us. So type 1 diabetes, it actually is also a spectrum. And so on the tip here on the left, we say that that would be classic type 1 diabetes. And classic type 1 diabetes has some features. It tends to be diagnosed at a younger age. They tend to have normal insulin sensitivity or a good sensitivity to insulin. And then the other thing is that at the time of diagnosis, their pancreas is producing not much insulin, it's probably producing very little insulin. Usually people say that their level of insulin production from the pancreas at the time of type 1 diabetes diagnosis compared to normal is usually about 10% or less function of the pancreas that they have at the time of diagnosis of type 1 diabetes. But why do we say it's a spectrum? Well, some people are getting diagnosed not as young as the whole classic type 1 diabetes. We're finding that some people living with type 1 diabetes can lose their sensitivity to insulin, and they can actually develop a resistance to insulin over time. And then the other thing we're also seeing is that the amount of insulin that their pancreas produces can vary quite a bit from person to person living with type 1 diabetes. So that's why we say it's a spectrum. Let's take it to the other side. So this extreme point here on the right would be the so-called classic type 2 diabetes. And that, classic features of that would be diagnosed at an older age. They have resistance to insulin, and it's a resistance to insulin. However, usually their pancreas, at least at the time of diagnosis, is still producing insulin. So you have a pancreas producing insulin, but you're getting resistant to insulin as the main pathophysiology or the main features of type 2 diabetes. The other thing is classic type 2 diabetes tends to occur in people who have some excess weight, either they're overweight or are living with obesity. So those are classic cases. But why are we saying that type 2 diabetes is also a spectrum? Well, we're finding over the years that people can be diagnosed with type 2 diabetes at a younger age than the so-called classic time of diagnosis of type 2 diabetes or age of diagnosis. We're finding that the level of insulin resistance can be quite variable as well between different people who have type 2 diabetes. And then the weight issue, I mean, it's still mostly people who are overweight, but not always. So that's also a spectrum. So that's type 2 diabetes spectrum. And then in between, exactly as was very well done in the introduction, is that we have this part in between that is LADA, also called type 1.5 diabetes, that has features of both type 1 diabetes and type 2 diabetes. So a few things to discuss here. It tends to be diagnosed at an age in between classic type 1 diabetes and classic type 2 diabetes. Again, there is going to be a variety in the age that when it's diagnosed. And then the weight issue, some people are of normal weight during diagnosis, some people might be overweight, some people might be living with obesity. So that also, there's the overlap. And then finally, the one thing about LADA that we also need to make sure that we delineate is that the people living with LADA, the pancreas function is starting to decline. Okay, as to how quickly or how slowly it declines will vary from person to person living with LADA. But as we've already mentioned, it's generally a slower decline in the pancreas function compared with more classic type 1 diabetes. So that's why. So LADA itself also is on a spectrum. Okay, so the common diagnostic criteria for LADA comes from the Immunology for Diabetes Society. They list 3 diagnostic criteria. So first one is age, above 30 years. Second criteria is positive for diabetes-associated autoantibodies. So antibodies are part of our immune system. The normal job for antibodies is to attack viruses and bacteria. However, there are conditions that are autoimmune, and that's when somehow the antibodies start attacking our cells. And then for LADA, these autoantibodies are the ones that the net effect basically decreases the pancreas function and the pancreas ability to produce insulin. So LADA is associated with these autoantibodies. And the last criteria is that insulin is not required for at least 6 months after diabetes diagnosis. So these are the 3 presented criteria. However, there are concerns with actually every single one of these diagnostic criteria, despite them being the most commonly used criteria over the years. So first one, the age of 30 years, it's a rather arbitrary choice. They basically want to make a point that it's diagnosed of adult age, but really why is the cutoff set at 30 versus 29 or 31? There's no real real answer behind that. They just kind of had to choose 30 as something to present in their criteria, 30 years. The issues with the second criteria is these autoantibodies. So of those autoantibodies, anti-GAD antibodies are the most commonly tested, for sure. However, what type of test was used? So there are actually many different ways to test, many different methods to use biochemically to test for anti-GAD antibodies. So the type of test used will, may classify certain people as positive, and a different test might classify a different subgroup of people that are positive for these antibodies. So the type of test, the method of testing is important. What cutoff did they use, right? So if they use a cutoff, like certain cutoff, if they change the cutoff, you're going to change how many people were positive and how many were testing negative. Any type of test is going to have a risk for false positives. So that can also happen. And then if you see in this criteria, they didn't really tell us which antibodies they're looking for. So can it be a combination of other antibodies? It could be. And some groups, when they study people living with LADA, have defined it based on other antibodies. That's possible too. So all this to say is that this criteria number 2, depending on how it's interpreted or how it's satisfied, can actually lead to quite a bit of differences in the LADA population that would fit that criteria. The third criteria, insulin not required for at least 6 months after diabetes diagnosis. First of all, it's difficult to diagnose this condition. So when do we start counting the 6 months is I think the main question here. If it took a while for the diagnosis to become apparent, then if we had to go retrospectively, when do we start counting these 6 months, right? Another concern about this criteria is who decided to start or not start insulin. We'll see when we present the classes of medications that can be used to treat LADA, that insulin is just one of the options. So often we know we really want to go with shared decision making. So between the doctor and the patient, we want to tell you the options and what your preferences are, which side effects you will tolerate or not. And then it's a shared decision, right? So if it's a patient who wants to delay starting insulin, or it might be the doctor who wants to delay offering insulin, that all affects how we count these 6 months criteria here in number 3. So lots of questions that can come from this diagnostic criteria. And for this graph, I just want to show one thing. So on the y-axis is the percent that are anti-GAD antibody positive. And I want to direct your attention to this bar here. So in this study, this is a control population without diabetes. Okay, and then here they actually found the false positive for this anti-GAD antibody was 2.5%. So that's just to let you know that, criteria number 2, be careful with it because it can also give false positives. Okay, so, but then really over the years, this is still the most commonly used diagnostic criteria. So let's keep them in mind. So we know there's an age criteria. The second criteria is autoantibodies related to diabetes. And the third criteria is some period of time not requiring insulin. Although these criteria do not necessarily define LADA, what we would recommend is that we need to keep in mind and go looking to detect these features to think of LADA. So as long as we think about it, I think it's more likely that we may catch it, although sometimes it does take time and more information for it to become very clear. So treatment for LADA, health behavior modifications, that goes for all sorts of diabetes, so that's always good. Medications can be personalized. We'll show more of that as we talk about the medications. Really want to highlight that LADA is a heterogeneous condition. I often want to say that, different people living with LADA, they're going to have their own course of perhaps when the condition progresses. So no need to compare one person to the next because you're probably going to run your own unique course. Therefore, that also leads into why the treatment effectiveness will vary. Certain classes of medications somebody might respond very well to, but another person with LADA may not respond well. And that's nothing to worry about because people will chart their own course and will respond in their own ways. The best thing I think that comes out of all of this is that we know for sure now that Breakthrough T1D offers great support and they offer it for people living with LADA. So that's awesome. So now we dive into the classes of medications for LADA. I need to spend a bit of time here. Just to draw your attention to here, this little graphic here is a pancreas. So of each of these classes of medications, so insulins, right? That's a whole, it's a, lots of different types of insulins. It's of course fair game, right? It's a good choice for people living with LADA, especially if we know the pathophysiology. The reason that this condition occurs is because the pancreas is not functioning well and pancreas produces insulin. So to treat it with insulin would be a very reasonable choice. Okay. Next class of medications, metformin. It's a very common class of medications for type 2 diabetes. But if we focus on what is the benefit or what is the utility of metformin for people living with LADA, I would say it's mostly two things. First of all, it helps with the blood sugar control. And then second of all, is it if the person living with LADA doesn't have a so-called normal sensitivity to insulin, if they're developing a bit of insulin resistance, for example, that can occur, then the metformin can help to improve the sensitivity to insulin. So those are the major reasons for its effects in LADA, and it's usually considered a good choice for people living with LADA. This here, I call this class of medications incretin-related medications. It's also part of my my aim is not to use brand names in this talk. So this class of medications can go by incretin-related medications. So incretins are a group of hormones that our body produces after meals. So when we feel full, when we've eaten enough, then our body produces these incretin hormones, sends the message to our brain to say, yep, I'm full, I'm happy, I've eaten enough. So this type of medication is basically these incretin hormones that were produced, and it's either given as an injection or a pill. The focus for this incretin-related medication class of medications for people living with LADA is that it protects the pancreas. It has protective effects for the pancreas, which is why we like our pancreases. We like to keep our beta cells that produce the insulin happy for longer. So that's the mainstay. That's the main reason why this class of medications is good for people living with LADA. This class of medications, sulfonylureas, are very questionable, and many people would say to not use it if your patient is confirmed LADA diagnosis. And the reason, so this class of medication, again, it's a common one for type 2 diabetes. The way it works is it pushes the pancreas to make more insulin. So it pushes the beta cells in the pancreas to go into overdrive. It's almost like putting a motor into overdrive and trying to force it to produce more insulin to help with the blood sugars. The concern with that for people living with LADA is that it doesn't have the protective effects on the pancreas. And because it doesn't protect the pancreas, it's why most people say that we try not to use it in people living with LADA. I always say never say never. There might be some cases when people want to use it, but generally speaking, it's a class that's usually avoided in people living with LADA. And the last class of medications, these SGLT2 inhibitors. So SGLT2 is found in our kidneys. And these SGLT2 inhibitors, the way they act in the kidneys is that they will make more sugar, glucose, go into the urine, and basically it's excreted, right? So sugar leaves the body in the urine. So that's how it helps with sugar control. But the concern for these SGLT2 inhibitors in people living with LADA is there is a risk of something called ketoacidosis, right? And then this risk of ketoacidosis with this SGLT2 inhibitor class of medications, it really is present, or it's really becomes a concerning risk when the body sees that there's a lack of insulin. So insufficiency in insulin. So when the body is in a state where they detect that, body says, I don't have enough insulin on board, then the risk of ketoacidosis is present if you're also taking SGLT2 inhibitors. So I put a question mark there because, there are cases where, so insulin insufficiency, right? So which conditions could the body be more at risk of insulin insufficiency, not having enough insulin in the body? Really, it's type 1 diabetes, people living with type 1 diabetes, and people living with LADA. So the cases where this class of medications might be used is if the treating doctor is quite certain that your patient has a low risk of becoming in an insulin deficient state. So then in that case, if they're pretty confident, you know what, this person's risk of being insulin deficient, having not enough insulin body, is the risk is quite low, then they might think, okay, then there is advantages to starting on these SGLT2 inhibitor class of medications. So it's possible. It just is it's more personalized to discuss with your healthcare provider. Okay, so choosing medications, we always weigh, I say you always have to weigh the benefits and the side effects. And the guiding principles to start or add medication is it depends on your individualized glucose glycemic targets and also shared decision making, right? Decide together. So now we launch into the examples of common real-world clinical cases where LADA becomes a diagnosis. Full disclaimer, none of these are real cases. However, they were all inspired by cases I've seen in the real world. So they are meant to represent real-world cases. Okay, so the first case is Mr. Ideal, a 35-year-old male. So we're going to give you the timeline here. I don't see him in clinic until later, but it starts off, the diabetes diagnosis was December 2023, on-off metformin during that time. February 2025, let's say I see Mr. Ideal in my diabetes clinic as a new consult patient. At that time, his hemoglobin A1C is 7.5%. So I'm sure you're all aware, hemoglobin A1C is a marker of the blood sugar control for the past 3 months. Targets are personalized and will vary, but in somebody who has, very low risk of low blood sugars and is able to take charge and manage their diabetes medications themselves, then often the HbA1c target is around 7.0%, right? So either case, his sugars are a little high for his own goals. So when I see him in consult, in my note, I probably will say I'm thinking DM, which stands for diabetes mellitus. And I intentionally, in my note, I would not specify the type because I think it remains to be determined. He's been on-off metformin, so I was like, okay, you can continue metformin, no problem. But let's do some investigations. And you probably guessed it. One of them things I was sent him for is the anti-GAD antibody. I'm in where I practice. Usually the results take about 4 weeks to come back. So they come back a month later, they're positive. Okay, so a few things to keep in mind. So the age, remember, that's one of the criteria for LADA. This anti-GAD antibody positive, that's another criteria. And then if we take a look at when he was diagnosed, and even up to now, he has not required insulin therapy, right? So you could say he does fit all the criteria, right? So that's why in the follow-up, I would say fits LADA, probably, that's what I would say in my note. And then we'd have a discussion and I'd probably offer him, the classes of medications that we discussed. And Mr. Ideal was very much liked that the incretin-related medications can have some protective effects on his pancreas. So that's what he chose. All is well, and that the next follow-up, hemoglobin A1C, the blood sugar control is a little bit worse than before, but he assures you, you know what, he wants more time just to see, and he doesn't want to change. You don't want to add anything at that time. That was your shared decision making. Okay, great. And then in January 2026, you're like, uh-oh, something's up, right? Because the hemoglobin A1C, that's a pretty big jump in 3 months, right? It's actually quite a big spike. So you ask Mr. Ideal, and he tells you, you know what? No, I eat really well. I exercise regularly. He takes all his medications, and he's like, nothing has changed in my life. So to cause this, so you're like, okay. And then everything taken together in your assessment, you're like, ooh. Then what's probably happening, because you're thinking he fits LADA, what's probably happening is that his pancreas somehow between the last few months, this last several months, has really declined in function. So pancreas over time has declined in its ability to produce insulin, and probably a very sharp decline happened in the last few months. And that's probably the reason why his sugars went high rather quickly. So everything in context, you discuss and you think probably the suggestion would be to start insulin, and then you gave him the options and he chose the basal insulin option. So this is I would say it's you'll see it when we go to the other two cases. This is a more straightforward case of a LADA diagnosis. I would say because we kept the diagnostic criteria in mind and we said, well, it fits, right? Okay, so now let's go to a bit more complicated cases. So we're just going to bring your attention back to this. So this case, first case, kind of just fit everything because we kept it in mind. We were looking for the features. Okay, next two cases, I'll show you how somebody could be initially thought to be diagnosed as a type 2 or a type 1, and then how over time we gain more information and we're like, oh, probably the diagnosis is LADA. So this is case 2. So we have Mrs. NR2, a 65-year-old female. So this is the history that you get from her. 2022, she was diagnosed type 2 diabetes, started on metformin since 2022, has been on it since then. 2023, she starts on the SGLT2 inhibitor class of medications. And then a few months later, she ended up in the emergency quite unwell. And then the testing and everything, emergency physician said, okay, you have this condition called euglycemic ketoacidosis. And remember the ketoacidosis that we talked about, right? And that's associated with SGLT2 inhibitors. So very astutely, they stopped the SGLT2 inhibitor at that time. Just going to bring your memory back when we talked about the classes of medications, that for SGLT2 inhibitors to have the risk of ketoacidosis, that means when this occurred in this patient, her body was saying, I don't have enough insulin on board. That's how she tipped into ketoacidosis. That's thought to be associated with this class of medications. Okay, so keep that in mind. So 2024, she started on sulfonylurea class of medications. And then 2025, her doctor following her at that time wanted to try the incretin-related medication class. She did try, but she couldn't tolerate the side effects, so they stopped it. So she comes to my diabetes clinic, January 2026, as a new patient. Her hemoglobin A1C is 8.0%, a little high for her, given her personal targets. And then everything, when I took the history, if I got everything that we just went through, I think for me, I have suspicion of LADA here. A big clue, so if we go through our criteria, so yeah, she fits the age criteria. I'm probably going to be sending her for the anti-GAD antibodies, if you probably guessed that. And then the big clue in her history to me is that she had this ketoacidosis develop related to this class of medications, because somebody who like a more classic type of type 2 diabetes, for example, you wouldn't expect somebody to have only been diagnosed for a year or two to actually be in a state where their pancreas is not producing enough insulin. Okay, because just recall, type 2 diabetes, usually your pancreas is producing insulin. It's just that you're more resistant to the insulin that your pancreas is producing. But it's not very common for somebody to have only been diagnosed for a short amount of time to get into a phase where they're actually having ketoacidosis because the pancreas is not producing enough insulin. However, if we put our suspicions for LADA out there, could somebody with LADA be in a case where they would have already, the pancreas is already not producing enough insulin? That would fit, right? Because LADA is by definition, like you have decline in your pancreas function. So if she had LADA, then it's possible for her to have had the decline in the pancreas function so much that the body was saying, I don't have enough insulin on board, and hence she had this ketoacidosis presentation. Okay. So in her classes of medications, the one thing we need to be careful of, so this SGLT2 inhibitor was already stopped in the emergency. Great, we're definitely not going to restart that in her, at least for the time being. Okay, it could be discussed later, but at least right now I probably wouldn't. And then the sulfonylurea, she is currently on, but remember we said that this class of medications doesn't protect the pancreas. So probably we're going to suggest that if I really think it's LADA in her, I'm probably going to suggest it's not the best choice to continue. So fast forward a little bit, we send her for the anti-GAD antibody test. It comes back positive, fits everything that we're thinking, right? We tell her it fits the LADA, and our suggestion is to stop the sulfonylurea, and then we discuss the insulin options. Okay, so this is a case, so this is a case where if we look back, it's the initially diagnosis type 2. Over time, we had more information, and then ultimately, retrospectively, we think it probably was a LADA case. It fits. Great. So the last case here, we have Miss Juan LADA, our 35-year-old female. So her trajectory goes like this. In June of 2024, she went to the Emerge, very unwell. She was diagnosed with type 1 diabetes. At the same time, she was started on basal bolus insulin. So I'm sure you're aware. So the basal insulin is your usually once a day insulin. And then your bolus insulin is also called rapid insulin, mealtime insulin. It's what you take to cover the sugar load or the load for each meal. Okay, and then so part of her diagnosis, they want her to check her anti-GAD antibodies. So anti-GAD antibodies are very common in people living with type 1 diabetes, so it's perfect to check it, and it makes sense that she was positive, right? And the more history you get from her, you're like, oh, okay, this is a concerning part. So she tells you basically since July 2024, she had frequent hypoglycemia, very frequent low sugars. And you're like, well, that's very surprising. And so you push her a little bit more to tell you more about that. And then you get the full history is that basically since she was started on insulin in June 2024, she has had to eat, and she eats so much more than she did before she was diagnosed with type 1 diabetes and started on insulin. And the reason is because she tells you is that if I don't eat, then I will get lots of low sugars because the insulin dose that they're giving me, like I will have low sugars unless I just eat a lot. So because she's had to push herself to eat so much to avoid low blood sugars, she's gained weight over time. And also her mental health has been affected. She has an ongoing fear of low sugars. And she doesn't like the weight gain that has happened either. The other part that you also get from her in terms of history is like, so because she's having these frequent hypoglycemias, low sugars, they had to decrease her insulin doses over time as well. Now, actually, she's taking around just 0.1 units of insulin per kilogram of body weight per day. So she weighs around 90 kilograms. So her total insulin, basal and bolus insulins together adds up just to about 9 units per day. So that is actually considered a very low dose of insulin. And at this dose of insulin, like we can be theoretically we would basically be able to hypothesize that her pancreas is working because your daily insulin requirements, if your pancreas wasn't working, would be higher than the 0.1 units per kilogram per day that she is currently taking for injection insulin. And then even on this very low dose of insulin per day, she still has, if she doesn't eat a lot, she may still go into a low blood sugar range. Okay, you get all that history and you're like, whoa. So she comes to your my diabetes clinic, let's just say in January 2025 as a new consult. You see that hemoglobin A1C. So I'm just like, okay, first thing I would say to her is that's one of the lowest hemoglobin A1Cs I would see in my diabetes clinic usually. And I got all that history from her and I was like, okay, you know what? I think probably you had LADA or you have LADA. So, and just go back here, the things that we talked about, right? So the age fits that criteria. We have the antibody criteria. And then, yeah, she's on insulin, true, but like, did she really need insulin if she's basically having to eat to make up for the tiny insulin doses that she's taking? So arguably, you would say it's such a low dose of insulin and she's having to eat so much. If we were to tell her that you can go back to eating normally, would we be able to stop the insulin? Does she really need the insulin is really a question, right? So recommendations at this point, we could check. I'm basically thinking that because her insulin requirements are so low for the injection insulin that she's taking, it does really seem convincing that her pancreas is producing insulin. So we can check for that. There's a test called C-peptide, and C-peptide is very much a marker of just the insulin produced by your pancreas. So we can definitely check that. And then because of her frequent low sugars, and it's such a low dose of insulin that she is taking, we can stop the insulins because it's already a very low dose, and we'll monitor her glucose very closely. Okay, so fast forward a little bit. We did our shared decision making. We explained it and she accepted. So we stopped the insulins and we monitor closely. So in the follow-ups, right? So in April 2025, her continuous glucose monitor time in range 90%. This is with no treatment, right? She's not on any medications for her LADA. And then August 2025, that appointment, her CGM time in range is around 80%. Okay, it's still acceptable. And then January 2026, time in range is about 70%. So we see the trend in the decline in the time in range. And then the A1C, the hemoglobin A1C is increasing a bit, now at 7.7%. So we discussed all the options of the classes of medications that we can use for people living with LADA. And, we did say the incretin-related medications have the pancreas protecting effects. And then we had to discuss the potential gastrointestinal side effects with that. And we discussed also the potential side effects with the other class of medications. Ultimately, for Miss One LADA, she chose metformin to start, but she's open to adding the she's open to adding the incretin-related medications as a next step, as an add-on if metformin doesn't, get her sugars in target. And she's open to considering the other classes of medications as well, but as add-ons in the future. So we'll continue following. So she is a case where she was initially diagnosed as type 2, right? And then with more information, we're like, it's probably a LADA. So we've presented a straightforward case of a so-called straightforward case, more straightforward case comparatively of LADA first as our first case. Our second case showed you how somebody could be diagnosed as type 2. And then over time, we get more information. We think it was more a LADA. And then our last case was somebody initially diagnosed as type 1. We get more info and we're like, probably it fits better with LADA. Just to show you, these are all inspired by real world cases. So these are things that we would see in clinic. So our take-home messages, so LADA, it's very challenging to define or diagnose. It can present and progress in various ways. It often takes time to become more clear, as you saw with the examples. It can have personalized medical therapies, absolutely. And a key feature is that it requires healthcare provider follow-up for things to become more clear. So excellent resources offered by Breakthrough T1D. And also I'd really like to highlight the Better Project, type1better.com, also provides excellent resources for people living with type 1 diabetes and also people living with LADA. So these are my references, and thank you all very much for your attention. And now we're open to question and discussion.
Thank you so much. That again, and everyone, just to let you know, Dr. Sun did this presentation in French just an hour ago. So then we have a lot of questions in the chat. I'm not sure we'll be able to get to all of them. The first question, which I think it just requires some clarification, they were asking, so type 1 has around 10% islet cell function and type 2 around 50% islet cell function at diagnosis, but that wasn't what you were saying, I don't think.
I'm wondering, so at the time of diagnosis, type 1 diabetes, it's usually thought to be around 10% or less of pancreas function. So I did say that type 2 diabetes at the time of diagnosis, it's I didn't say that, but I could see how some studies might have said it that way, but I would just say, at least from what I've read, the percentage of pancreas function at the time of type 2 diabetes diagnosis can vary quite a bit, actually. It also has to do with how, it also has to do with how type 2 diabetes, it's often thought to be diagnosed later as well. Like people with diagnosed type 2 diabetes, often people think they might have had it for a while before diagnosis. It depends. Some people are followed more closely by their doctors, so they would have diagnosed it really quickly. But some people, it's a delayed diagnosis as well. So that probably also affects too, like in the literature, the quoting percentage of pancreas function at time of type 2 diabetes diagnosis. But I would say it has to be a range. There's probably quite a range of percent of a residual pancreas function at time of type 2 diagnosis, type 2 diabetes diagnosis. Yeah.
Heather is asking if it's true that there are more older people being diagnosed with LADA than there are kids with type 1. And I know about 70% of diagnoses in Canada are in people over 18, but I think the number we know is about 10% of overall diabetes diagnosis is LADA. Is that your understanding as well?
That's what I've read. Actually, when I was preparing for this talk as well, the percentage of LADA, I saw quite a bit of variability depending on which study I was reading, and then many reasons, right? So people were saying like which diagnostic criteria did that group use to say this is LADA or not. Also goes into which type of testing, which type of method of testing for those antibodies, which cutoff they used, would have all influenced how they define LADA. And then there's another thought where they thought that LADA in different ethnicities, that's why it can vary as well. So that's why you'll see studies from different countries, certainly from different continents, will quote you different percentages. So the 10% is often quoted, but that actually is also a range. I think I've read anywhere between 2 to 12% in terms of percentage of people being LADA.
Not sure you would know the answer to this, but Gail was asking if someone diagnosed type 1 in 1985 would have been tested for the GAD autoantibodies.
That I'm really not sure. The other thing, I guess you could, one way you could see it if you had records back then. The other concern is, again, anti-GAD antibodies, we would call it the first generation of tests, are probably quite different than what they use now. So yeah, I'd say unless you have it in your records and if you can figure out what type of testing they used back then. My understanding at that time, they were still improving the antibody testing methods. So yeah, so it's hard to say depending. Yeah.
Karen was asking if it's possible for doctors to do that get autoantibody test, pardon me, alongside with A1C. I would imagine not in anyone, but in someone whose A1C has been showing variation, as they were misdiagnosed for 10 years.
Yeah, so I mean, as you can see, like in the criteria, the antibody is one of the criteria, right? So the antibody alone is not really, it probably won't be the factor to change somebody's diagnosis. It's probably they had other factors as well that of which the antibody result was complementary or fit with the initial clinical suspicion or something like that. So, I mean, just to say that we don't like, we wouldn't HbA1c, like a hemoglobin, we check and we monitor, but anti-GAD we would do if we had a clinical suspicion that this person may have either, maybe living with type 1 diabetes or LADA. So we have to have that clinical suspicion there before we would order the anti-GAD. And usually it's only done once. It's not common for anti-GAD to be followed over time. I say never. So there probably are conditions clinically where your provider would say, okay, I have a reason for ordering it again, but it's not routine. Yeah.
We have a few questions about the incretin-based meds. So I'll kind of group them together for you because there's one if they are good for patients with obesity. Can you use it in conjunction with insulin or does it need to replace insulin? And can you still get treated differently medically if you're diagnosed with LADA even after you're insulin dependent if you're on incretin? And do they stress the pancreas by stimulating insulin production? So that was a number of questions all related to the same topic, but
Okay, I've just been jotting down some notes here. So if I miss anything, let me know, but I'll try to go in order. So yes, this incretin related class of medications, definitely it's a huge it's the huge obesity treatment medication that's all over the news, right? So yes, definitely it's the same. If you're wondering if it is the class of medications, that's the super popular class of medications for treating people living with obesity. Yes, it is. So the next part, I think they were asking, can the incretin-related medications be used with insulin? I suppose this question is basically, can the incretin-related medications be used with insulin in people living with LADA or people living with type 1 diabetes? Yes, it can be. So I think for two reasons, right? So because it's also used to treat obesity. So if the patient also has obesity, that'd be one reason why we would use it as well. And then the other reason is if somebody's already started on insulin, could we start this incretin-related class of medications? We can. And then the effects that we're seeing is often people's insulin doses can decrease because they, depending on how they respond to these incretin-related medications, if they respond well, then their insulin doses can decrease quite a bit. Again, there's variability in how somebody responds. So some people, they don't respond as well, and then the insulin doses don't change as much. But for people who respond very well, like have I seen it where I start them on an incretin-related medication and their insulin doses decrease quite impressively? Yes, I've seen that too. The next part is, oh, can somebody insulin dependent be also on incretin related medications? Yes, right. That's part of what we already just discussed, sorry. And then, the last, I think they were asking, can the incretin related class of medications stress the pancreas? Was that the question as well? Yeah.
yes.
So I understand where that's coming from because one of the mechanisms of action of these incretin-related medications, there's like so many mechanisms of action of how it acts. But one of them, there is one that in the literature you'll see, they do think that it can push the beta cells a little bit to produce more insulin. So you're wondering, doesn't that stress them out? Probably to some extent. However, the overarching effect that comes from all the studies of these incretin-related medications, the overarching effect is that overall they find everything balanced out. They find the net effect is that it's still protective on the pancreas. So net effect wise, we still recommend it for people living with LADA because everything kind of weighed together. They still think the benefits of pancreas protection make it useful for people living with LADA.
We have so many questions. We only have 10 minutes left. I'm going to try to get to the ones that I think will hopefully be a benefit to the entire group. Linda was just asking what the difference between the GAD test and C-peptide testing is.
Okay, great question. So C-peptide is a direct measure of how much insulin your pancreas is producing. Okay, this came up in the last group as well, but I also say that one thing I didn't say in the presentation, if you ask for more about C-peptide, is whenever the C-peptide test is drawn, whenever blood work is drawn for the C-peptide, also check your blood sugar at the same time, because interpretation of C-peptide has to be done in context of the blood sugar. So for example, if your blood sugar is quite high, you would expect, a pancreas with more function should be producing more insulin. But conversely, if the blood sugar at the time of the C-peptide test, if the blood sugar was rather low, then you would expect a pancreas to know that the blood sugar is not high. So the C-peptide level, the pancreas production of insulin shouldn't be high either, right? So always draw the blood sugar with the C-peptide, because C-peptide is how much insulin your pancreas is producing in context of what your blood sugar is at that time. And then the other thing to mention about the C-peptide testing, it's best interpreted for each individual. So if you really want to know your pancreas insulin production over time, it's best to do it in the same individual over time. And then you'll see the progression of your pancreas's insulin production capacity over time, how it has changed in yourself. And then the question about the anti-GAD antibody. So the anti-GAD antibody, it's an antibody that attacks it's an antibody that decreases your pancreas's ability to produce insulin. So that test is the antibody itself versus the C-peptide test is how much insulin your body is producing. So for example, somebody could be like you could take two people who are both anti-GAD antibody positive, so they have these antibodies that are kind of impairing or compromising how much insulin the pancreas can be producing, but the actual effect of the antibodies on the pancreas on the pancreas's ability to produce insulin can be different. So somebody could have a higher C-peptide than the other person, for example. So that's how they're different, these two tests.
So there's some questions as well about insulin sensitivity versus the autoimmunity. And can they exist together, or do they coincide? Are they different things? Are they treated differently?
Okay, yeah, no, that's a great question. So autoimmunity, the anti-GAD antibody or whichever auto antibodies we're testing, they think of them as their own entity. So think of that as you tick that criteria box that we have some evidence of antibodies that are going to contribute to decreasing your pancreas's ability to produce insulin. Insulin sensitivity, think of it a bit separately, because if we take same two people that are both positive for, say, the anti-GAD antibody, they could have different levels of insulin sensitivity. Somebody could be more insulin sensitive to insulin than somebody else. And then in terms of how their insulin sensitivity progresses, like whether their insulin sensitivity declines over time, it's again going to be very unique to each person. Somebody's insulin sensitivity could decrease quite quickly, whereas somebody else's could decrease quite slowly. They might all have similar levels of this anti-GAD antibody, but the impact on how sensitive they are to insulin can be very different.
And there was a question that if you become eventually completely insulin dependent, are you still considered LADA, or are you type 1 at that point? And the second part, which is a different question, but I'll ask at the same time, is if you are not requiring insulin, but you've been diagnosed, are you actually LADA, or are you in early stage type 1?
Excellent question. So the first part, if It's actually, so I'll preface this by saying that there are many people who who say that LADA should just be type 1, right? LADA is just a subtype of type 1. So there are people who definitely would say, like, why are we making the distinction if LADA is just a slower progressive form of type 1? So along those lines, so the first question being, if you're dependent on insulin and you fit the criteria for LADA, then if your doctor keeps on saying in their notes that this person has LADA and is now currently treated with insulin, then I would say that's perfectly fine to say that you still have LADA and you're just insulin treated at that point. And sorry, the second question again, I lost my train of thought. I know it was about LADA and
if you're not on insulin, so the opposite of that, diagnosed LADA and the medications are working, are you an early stage type 1, or would you still be considered LADA
that's
as
an
a
excellent
separate
question.
classification? Yeah.
That's an excellent question. That's very hard to answer. So you'll see that even so, actually, if we take back to our first case, it's almost like the case that we're saying. So we had our suspicion for LADA when the patient first came to clinic, and this person wasn't. Oh, I think when we had the suspicion for LADA, he was only on metformin, right? So I already had the suspicion for LADA, and I thought, because of the age criteria, the antibody criteria, and the time criteria, he met all three criteria. So at that time, if I was going to say in my notes, he fits all the criteria for LADA, but is just on metformin right now, then yeah, it is still considered. We can still consider it LADA, but just treated with non-insulin medications for the time being. So basically, what I'm trying to say is that if it fits the criteria, the classic criteria, and at some point during our follow-up, we can say, it fits the criteria, but this is what they're being treated with right now, and let's continue following and see what happens. Yeah.
And there was the question, how do you differentiate LADA? And I'm not sure what from it's MODY. I don't know what that stands for, so I'm hoping you
MODY,
do.
yeah.
Yes.
So maturity onset diabetes of youth, I believe. So it is quite different. So I would say that the three criteria that are used for LADA are not, like, it'd be very hard to find somebody with the MODY that would fit the criteria that we generally use for LADA. So yeah, so if you really had that question, you could ask your healthcare provider why that wasn't, like, you're pretty sure it's LADA and not MODY. But usually people with MODY, it'd be hard pressed for them to fit the LADA diagnostic criteria.
And I'll try to just ask two very quickly, and then I think we'll wrap it up because you've been speaking for 2 hours straight. Is it worth continuing to take the medications that protect the pancreas if your C-peptides levels are so low that they aren't producing insulin? Their pancreas isn't producing insulin at that point.
That's an excellent point. So the medication mainly for LADA that protects the pancreas is the incretin-related medications, right? So if you're saying it's a case where their C-peptide is very low, probably this person has quite high sugars, right? So in that case, like if they're just on the incretin-related medications, if you're saying that now their C-peptide is low, probably their blood sugars are quite high, and probably at that point, like, it's almost, I think, one of our cases, I believe, is case 2 that we presented, where their A1C just went up really quickly. So you would assume if we were to measure C-peptide in that person before and after that huge increase in their A1C, that their C-peptide would have decreased quite a bit. So in those cases, if they were on incretin-related medications and C-peptide became very low, blood sugars became very high, we would probably keep the incretin-related medication and then discuss with them to start on insulin.
And just the final question that I'll ask is if weight loss becomes excessive with the incretin, pardon me, related drugs, but it's managing the glucose levels well, is it worth it to continue on them at a lower dose?
You could, definitely part of the shared decision making. So if that becomes a concern, definitely let your healthcare provider know. I've definitely seen cases where we've lowered the dose and then they found the weight was more acceptable, more to their liking. So we've definitely done that. So again, case by case, you could definitely, because you keep some of the benefits, right, of that incretin related class of medications. But to find that good balance point for each person, where they find the advantages and the side effects are more tolerable or more acceptable. So I could certainly see somebody just keep the class of medications, the incretin-related medications, and just decrease the dose. Yeah, we certainly could.
So we just got a comment. Great presentation, Dr. Sun. One of the best presenters I am aware of. So knowledgeable. Thank you so much. I think that is a very good summary of tonight. Thank you so much for everything, for putting together this presentation, for taking all of these questions. I put an email in the chat. I know we didn't get to absolutely everyone tonight. So if you do have follow-up questions, please just email us and we'll do our best to answer them as they come in. And the presentation will be sent to everybody tomorrow. And I also like to thank Abbott for their support of this presentation. But Dr. Sun, honestly, can't thank you enough. I've learned an enormous amount tonight, and I think so has everybody on this call. And we're very, very grateful for your time and efforts tonight. And if you have a chance to see the chat, you can see that you're getting lots of kudos from everybody. So thank you so much.
Thank you very much. Thank you to you and your team as well for this wonderful opportunity. Yeah.
And with that, we'll say good night.
Good night. Take care, everyone. Bye-bye.